This is the Whole Care Network. Helping you tell your story one podcast at a time. Content presented in the following podcast is for information purposes only. Views and opinions expressed in this podcast are solely those of the host and guest and may not represent the views and opinions of the Whole Care Network. Always consult with your physician for any medical advice, and always consult with your attorney for any legal advice. And thank you for listening to the Whole Care Network.
Treat the patient that we're seeing in the hospital environment, but that patient in their home environment is very different. And so a lot of times treatments that are prescribed from the hospital or the doctor's office don't necessarily work in the home as the same way. And we're able to really assess and evaluate that whole environment and figure out what's going to work best for this patient. Oh, well, this doesn't work this way because of what's going on in their house or whatever. So we can find things that work really well for the patients, and we make a big difference.
This is the Heart of Hospice podcast with Helen Bauer. Hospice nurse Shelley Henry is my guest for today's episode to talk about how she supports nurses working in end-of-life care and the meaning that hospice nursing has had for her. Whether you're a family caregiver or an end-of-life professional, the Heart of Hospice is here to enhance your hospice experience by connecting you with information you can use about end-of-life care.
This episode of the Heart of Hospice podcast is sponsored by the Tree of Life Conference by International Doula Life Movement. Join IDLM at the Tree of Life Conference in San Antonio, Texas, November 1st through the 4th. The Tree of Life Conference is more than just workshops and seminars. It's an opportunity to connect, learn, and renew your commitment to compassionate care. Attendees will hear from expert speakers like end-of-life educator Barbara Carnes and Death Deck co-creator Lisa Paul. Visit internationaldoulalifemovement.com for more details. This episode is sponsored by Hospice Navigation Services. When you need information about hospice, Hospice Navigation Services can help. Our team of experienced hospice navigators is here to offer one-on-one consulting sessions by phone or video. You can book a complimentary 30-minute session when you need general information, or book a 60-minute session when you have in-depth questions or need to troubleshoot your current hospice care. It's your journey. Hospice Navigation Services can be your guide. Visit theheartofhospice.com to schedule your hospice navigation session today.
Hospice nurses, it's all about us today. That's not true. We did talk about some other disciplines, but we talked an awful lot about hospice nurses. My guest today is Shelley Henry. She's a hospice and palliative care nurse with over 20 years experience in end-of-life care. She is the president of the Amity Group, a staffing agency that caters exclusively to hospice agencies. She's a committed advocate for hospice nurses and the hospice community at large. She does weekly videos that are shared across social media that provide tips for hospice nurses. They feature practical tips for everything related to hospice nursing, including time management, documentation, as well as self-care. You can connect with Shelley Henry on LinkedIn and amitystaffing.com. I asked Shelley to describe how she got into hospice in just 2 words, and she used the 2 words divine intervention. And you're going to hear her story and how she started working in end-of-life care. She learned very early on that being a hospice nurse is very different from other silos of nursing, and she's going to tell you why. She also shared the story of one of the most challenging patients she ever took care of when she was working in the field. It's a little bit of a tearjerker. You can tell it's a heart story for her. And she's also going to share how she created a nursing bag. She calls it the tag bag. And if you're a hospice patient or a hospice caregiver caring for a loved one in the home, or you're a hospice nurse, actually anybody working on the hospice team, you're going to know what a big deal it is for a hospice nurse to have a really good bag to carry supplies in. Shelley actually designed and created a bag of her own that she now sells to support other nurses. So sit back and relax. It's a great conversation. I hope you enjoy this interview with Shelley Henry. Shelley, welcome to the Heart of Hospice podcast.
Thank you so much, Helen. I'm so excited to be here today.
You are sort of a unicorn guest for me because we have actually met in person, which is really unusual. I don't get to do that with my guests. So it's kind of cool to follow up with you after we met at the conference.
That is, yes.
So I have an icebreaker question for you that I did not give you in advance. I love to do this. It kind of bamboozles my guests sometimes. This one's not bad. So what do you do when you want to relax after a long day? What's your go-to self-care?
Oh, wow. And I talk so much about self-care, and I am like every other nurse probably on the planet. I'm not very good at it. But my favorite thing to do is actually when I really just need to unwind is I spend time with my poodle. I have a giant poodle named Geo, and Geo has a great outlook on life. Everything is fun for him, and he's got this wonderful energy. And I can spend 20 minutes just focused on him and playing with him, and it just changes my whole outlook. It makes me realize that everything I think is so serious really isn't that serious, and life's about having fun. So that's probably what I do. Yeah.
So I have a therapy animal. I'm part of a therapy team. So my dog, Sunny, and I, he's a golden doodle, so he's part poodle. And I'm like that too. I spend 15 minutes, and of course it's all about I'm petting him, but I get the benefit of it. I can feel my heart rate come down and I get relaxed. Yes. I have a conversation with him, like most dog owners that are really, really close to their dog. I have ridiculous habits. Sometimes when I blow dry my hair, I use the blow dryer on him because he likes that.
Yeah.
I mean, it sounds a little bit crazy, but if you're an animal lover, a dog owner, you understand that those boundaries aren't as healthy as they should be.
No, there's no boundaries. No boundaries in my house.
Oh, I get that. That's a great self-care habit. And I love it that you talk about self-care and your self-care failings, just like every other nurse. Yeah.
We get stressed out because we're not doing our own self-care, and people tell us, well, you should be taking care of yourself. Well, I know, but there's just no time. And then that causes stress. So it's just this cycle that we get into that's hard to get out of.
It is. And I feel a little bit guilty because, of course, on the podcast, I'm constantly saying, oh, self-care is great. Mind, body, spirit. It's so important, whether you're a personal caregiver or you do this for a living, self-care. And then I don't do it. Not the way I should anyway. Sometimes my self-care is unhealthy. It's binge watching something and eating a bag of chips.
Right.
Yeah.
Do that too sometimes.
Yeah. Let's face it. We all do it.
Yeah.
So you're a hospice nurse. I would ask you, what 2 words would you use to describe how you got into end-of-life nursing?
So the first 2 words that come to mind would be divine intervention. I believe that I had been a nurse probably 10 or 11 years before I became a hospice nurse. And my background was ICU, critical care, high-level trauma, all of what they call adrenaline nursing, all of that. We're in there saving your lives, the kind of stuff you see on TV. That's what I did. And I loved it. I didn't know anything about hospice at all. And one of the nurses, I was wanting to do something different. And I was standing in a checkout line in this little tiny grocery store in the little town where I lived at the time. And I was talking to my mom about it. She was there with me. And someone taps me on my shoulder, and I turn around, and there's this nurse standing behind me. And she said, you should try hospice. Because I was telling my mom, I want to pick up extra hours, but I'm tired of being in the hospital. And I'm like, hospice? Like, isn't that where people go to die? Like, I'd been a nurse that long and still didn't really understand hospice. So that says kind of a lot right there about how misunderstood it is. But she said, if you really want to make a difference and get to be able to bond with your patients and make a difference in their lives, hospice nursing is where you should be. And I'm like, well, okay, yeah, I'll think about it. And I really didn't. I didn't think I would. But a couple of days later, I went on the job site. Back then, I think it was Career Builder or something. They didn't have Indeed back then, but whatever it was. The very first job that came up was for a hospice nurse. And at that time, there were 2 hospice agencies, I think, in my whole state. I mean, it wasn't like it is now where there's one. So the fact that the ad came up as the first one, I'm like, okay, this is a sign. And so I went, and it was for just an as-needed job, like a part-time PRN job. And I took it, and I realized really quickly that 2 things. First of all, you can't learn hospice doing it part-time. And secondly, it was where I was meant to be. I really felt like I had gone home. Like, I just got it. This is what I was supposed to be doing. And I ended up quitting my other job. And that was like 22 years ago. And I haven't looked back since.
I want to touch on something that you just said. You can't learn hospice with a part-time job or a per diem, PRN job is what we call it. You can't learn hospice that way. Expand on that. Why is that so difficult to do?
It's so very different. And so when you work in a hospital, if there's something going on with the patient, and it might not be your patient, it could be another nurse's patient stuff, you're kind of in that world and you're learning a whole lot more than you realize.
Right.
In hospice, you're in the home by yourself. So the learning that you do comes from your own personal experiences. I mean, we talk and we share things, but you really need to be out there doing it a lot to learn it and to understand it in the way that I wanted to learn it and understand it. Yeah, because you just have to have that experience because every patient is different. Every environment is different.
Yeah. And you kind of have to be immersed in it, I think, to really learn it. The reason I think that's an important thing to touch on is because I think that applies to more than just nurses. I have seen through the years that I've been in hospice that people are looking for retirement jobs. So they'll come to be a chaplain at a hospice agency, no experience, older adult, and thinking, I've had pastoral ministry experience, so it's the same. And of course, that's not the same as hospice chaplaincy. Or somebody's looking to supplement social work that they do, so they pick up a few hours. They want a part-time job working in hospice because you need a social worker. It's just not the same.
It's not. And it's so much, I don't know if harder is the right word. I can't think of a better word right now, but it's harder, more involved than people think. It's not an easy job for any discipline. It's very involved and very complex. Lots of nuances and lots of things you have to deal with at one time that in a clinical setting you don't have to deal with.
Right. I think the learning curve is a lot steeper.
Absolutely.
And I think when you're doing it part-time or PRN, you stretch that learning curve out. And the biggest impact I can say that has on what we do is our patients and their families do not have the luxury of our learning curve. They do not have the time. I don't want to say to waste, but that's accurate. They don't have time to invest in our mistakes or our newness.
That's such a great point.
Yeah, they just don't.
So true.
I feel very strongly about that. And we struggle with that in hospice work because we're short-staffed. And a lot of times, every discipline is carrying too many patients in their caseload.
Absolutely.
That's one of the reasons you do what you do at Amity, to provide staffing and supplement those nurses. Yeah.
Yes. And I was so worried that we were losing the experienced nurses. That's really why I started Amity, and our goal, all of our nurses are nurses with experience that got burnt out and left the field. So they've all come back through Amity. And so they're able to teach the newer nurses because it's a lot. There's just so much to learn. And that's why I do the videos and stuff too. We all have to share our knowledge the best that we can.
So let's talk about your videos, because that's really how I first became acquainted with you, was on LinkedIn. You post these awesome videos. You're sitting in your car. It's low tech. It's super practical. What kind of things are you talking about in your videos, and who are you talking to?
So I'm mostly talking to hospice nurses. So my videos are tips for hospice nurses. And I will talk about little treatment tips and things that I've found and tricks that I've learned just working out there. I talk about documentation stuff. That's a big thing for nurses, teaching them how to document easier and faster and more effectively. And I'll talk about self-care too, which we just talked about. We kind of fail with that, but I do provide tips. And sometimes I just talk about whatever's on my mind too. If I saw something that day and it's weighing on me and I just feel like, let's just put it out there. And, everybody else is probably feeling or has felt these things at one time or another. And I'm just trying to help hospice nurses not feel so alone, because it's a very isolating job as far as you don't have peer support as much as you do in any other kind of job.
That's true. We do support each other, but when you're out there on your own in someone's home, which is where most hospice care takes place, right?
Yes.
You're very autonomous. You're making decisions, teaching, supporting. You really have to bring your A game. At least we hope we do. But burnout for hospice nurses, years ago, I heard that it was about 5 years. 5 years that somebody would last. So for somebody like you to be in hospice 22 years, that's a huge achievement.
It is, but I haven't been in the field for 22 years. I probably wouldn't have lasted in the field for 22 years. I did move up into upper management type jobs and that kind of thing. So
yeah, that changes things. The burnout may be not quite as fast, but I would say it's still there. It's just different. It's a different type.
Definitely, if you're a leader at an agency level, that's probably like a DON. That's probably the hardest job anyone can ever do. That you probably got 1 year to 2 years in a lot of places, unless you have a great company is able to support you a lot, because you're never off. That's a really hard job.
Yeah, it is. It is. So when it comes to hospice and education out in the community, what do you think is the most misunderstood piece of hospice?
Oh, there's a lot. There's so many.
There's a lot.
The general is that it's about death and it's sad. When I tell people a hospice nurses almost universally get the same responses. Oh, I don't know how you do that. It's so sad. And I'm like, it's not sad. I mean, it is in a way, but we don't focus on death. And as hospice, we don't go in as like the Grim Reaper. We are celebrating life, and we're celebrating this person, and we're able to make such a big difference in their life and give them so much quality. And that's what we focus on. And that's really, when I think of hospice, I feel joy and I feel happy, and it makes me smile, because we do make that kind of difference. It's not sad, and we don't focus on death.
I think if you don't work in this industry, or if you have not been on the consuming side of hospice care, if you've never seen a loved one go through hospice, I think it's a little bit hard to understand. It's a weird concept that we find joy in working with the dying, but that's real for so many end-of-life workers. It's not that it's an easy thing. We do have patients that suffer. We have patients that don't have what they would categorize as a good death. Right? Because a good death is decided by the individual. We don't get to decide that for them. So yeah, the work can be really hard, but when it's right and it goes well and it's everything that patient and everything that caregiver wanted and needed, it's just amazing.
It's amazing. There's really no words to describe it unless you're there and sharing that space and that energy with that person. It's the most incredible thing.
Yeah. It really is. It's a very sacred moment.
It is.
To be able to be present at a time of death, or even just after as a nurse. It's really it's an amazing thing. We could probably do the whole podcast about nothing but how amazing it is.
Yeah.
So I want to talk about your background at the bedside. So you haven't been doing that for a while, but tell me about the most challenging patient or the most challenging situation you've had working in hospice.
There's been so many of those.
Yeah.
And I do actually with Amity, I do still go in the field. Like I make a point to go in the field no less than every 6 months. I'll go spend a few weeks in the field just so I can stay in touch with it. Yeah. And I think the most challenging, I had a patient, this was many, many years ago. And this gentleman had struggled with addiction for the better part of his life, and was estranged from all of his family and everyone that loved him and all his friends. He was pretty much all alone. And he had gone to, in the town where I live, we have a charity system in my state. So he had gone to the charity hospital, and that's where they had diagnosed him as having a brain tumor. And so then they just immediately call hospice. That was kind of their routine. Like the doctor tells them, and 5 minutes later, the hospice nurse is there. And that was me. And so I was sitting down talking with the men, talking to him about hospice and doing the same talk that I always do and all of that. And he's just looking at me the whole time. And I just stopped talking. And because I could realize, I felt like I wasn't answering him. I wasn't connecting, and I said, is there something you want to ask me or anything you need to know? And he just looked at me, and I said, I said, you want me to tell you that you're not dying? And he shook his head and he started to cry.
Oh, wow.
He nodded his head and he started to cry. And I said, I can't tell you that you're not going to die. But what I can tell you is that you won't be alone. You will have dignity and you will not be in pain. That I promise you. And so when we went from there, he said, okay, well, I'll do this. He lived in a halfway house with another gentleman. Both of them were recovering addicts. He had the brain tumor. We know how that progresses and the things that we have to do for intervention wise. So we have to have the medications. But how do you do that in this situation? Because we also didn't want to tempt his roommate. We could have put him in a nursing home, but I promised him we wouldn't do that until we got to that point that the brain tumor started to affect his reasoning. And he signed the paperwork, and the social worker took him out and found the right nursing home where he wanted to be, but we promised we wouldn't do it until the time was the time. And so the working with all of the nurses, the social workers, the CNAs, we all had to work in tandem because we had to go administer the medication to this patient. We couldn't leave it in the house. So we were seeing him 3 and 4 times a day sometimes. But we did that and it worked out, and everybody just pitched in and we just did it. And did it. He was able to stay in his house. We were able to actually even connect him with his estranged daughter who was in California. We were able to do that, bring them back together before he started to become confused and, like we usually see with brain tumors. And he stayed that way until we had to put him in the nursing home. And then even in the nursing home, it was all a good experience. It was a lot of work, though, and a lot of challenge to help this gentleman. But I will never forget him, and I'll never forget that experience.
I would say the first thing that really jumps out at me is, wow, you guys were making multiple visits a day. That's really unusual. For my listeners who don't know this about hospice, we typically don't do that. That's very unusual.
Very unusual.
Right? Medications are left in the home for the patient to self-administer or for a caregiver to administer. So for the nursing staff to go in and out to administer meds, because you're talking about everybody worked in tandem, but aides aren't allowed to give medications. Social workers aren't allowed to administer that. So the nurses were taking the brunt of those visits, the brunt of that workload. That's pretty amazing.
The aides and the social workers would call us and say, hey, I think that Mr. needs his medication.
Yes.
Yes, it is very unusual. And this was a different time, too. This was probably 15 or 20 years ago with a little bit different time. But no, we generally never see our patients 3 and 4 times a day.
No. And the rules have changed when it comes to opioids and who has access and how often they have access. With the crisis that we have dealt with opioids across the United States, that's affected how we manage them in hospice quite a bit.
Definitely has. I find it. It's made it so much more difficult, I find, than it used to be. We were able to do it. And I don't know your experience, but we never really had a lot of issue with it in hospice. But we just got caught up in all of that, I think, of what's going on everywhere else that's necessary, but
right.
It does make it a lot harder.
I think there was an assumption that it was happening wherever opioids were used. And so hospice got swept up in all that.
Yes.
And of course, it's different from state to state, how the rules are managed, how much can be prescribed and who can do it, what criteria you have to have. But I think they found out pretty quickly that hospice needs more latitude. It has to be more independent because our patients are different. Very different. We do have the same risk of diversion. I mean, you're talking about putting opioids out in the home where we have to worry about what we call diversion, which means somebody else taking medication that's intended for the patient. So that was, I guess, always a concern, but we have become, I think in the last 10 years, much, much more aware of how to manage that.
So we use a lot of lock boxes where it's locked in there, and they have the biometric where you got to use the thumbprint or you got to use the combination to get the medications out and keep them safe. I think we should do that in every home. We don't routinely do that in every home, but I think we remove the temptation and the risk, and it makes it, I think, a lot better.
Yeah, I think a lot of patients and families would feel more comfortable.
Yes.
Especially if they have multiple caregivers or hired caregivers coming in and out, people that maybe you don't know as well, you don't have a history with them. And of course, substance use disorder is a big issue across the U.S. We do have patients that are dealing with that, or they've had years of sobriety, or their caregivers are recovering addicts. They've dealt with it as well. So yeah, it is something that we address. In fact, a lot of patients and families, we do a risk assessment with them based on their behavioral history, drug history, anything like that. It can be a little bit of a heavier workload for the hospice team to have to help a patient like that.
But it's definitely doable. And I think that's important for everybody to understand. And you can ask for things like the lockbox if you want, because most hospices do provide that. And if you feel like you would just like to have that in your home, then you just ask your hospice if they can bring you one.
Right. It's not a big deal. Almost every hospice. And they're required to make sure that those medications are responsibly secured, things like that. So it's not really a big ask or a weird ask.
No, not at all.
No, that's sort of SOP for us. I hope you're enjoying this episode. We're going to pause for just a minute. My guest has more to share.
In a world where compassion and community are needed more than ever, the International Doula Life Movement presents the Tree of Life Conference. Join IDLM November 1st through the 4th in San Antonio, Texas for an extraordinary experience in end-of-life care. The Tree of Life Conference is not just an event, it's a movement towards making a positive impact. Attendees will hear from expert speakers including award-winning end-of-life educator Barbara Carnes, Lisa Paul of The Death Deck, Brenda Kazire and Nancy Hireman of Odonata Care, and end-of-life advocate Helen Bauer, host of the Heart of Hospice podcast. The Tree of Life Conference is more than just workshops and seminars. It's an opportunity to connect, learn, and renew your commitment to compassionate care. This event is made possible by the team at International Doula Life Movement, who believes in the power of empathy, education, and making a difference in the world. Don't miss out on this transformative experience. Join IDLM at the Tree of Life Conference in San Antonio, Texas from November 1st through the 4th. Visit internationaldoulalifemovement.com for more details and secure your spot today. When you need information about hospice for yourself or someone you care about, Hospice Navigation Services can help you navigate hospice care for the best end-of-life experience possible. If you're walking this journey and need the help of an experienced guide, Hospice Navigation Services is here for you. We understand the importance of having a guide who can provide personalized, unbiased support. Our team of experienced hospice navigators is here to offer one-on-one consulting sessions by phone or video. Whether you need information about how to start hospice services or guidance for your current services, we're here to listen and provide compassionate support every step of the way. You can book a 30-minute free navigation session with an experienced hospice navigator when you need general information to start your hospice experience. Book a 60-minute hospice navigation session when you have in-depth questions about hospice or need to troubleshoot your current hospice care. You deserve compassionate support and guidance for your end-of-life care. It's your journey. Hospice Navigation Services can be your guide. Visit theheartofhospice.com to schedule your hospice navigation session today.
So I want to talk about something that seems like a really small part of hospice nursing, but through the years, especially when I was in the field, I realized how big it was, and it's nursing bags and how we take care of patients. And the reason I'm bringing this up, I like this whole interview is because it's all nursing, right? It's all about us. You have designed a bag, and you actually sell a bag that's a nurse's bag for hospice nurses.
Yes. I do. So
why is that such a big deal for us?
So we have to carry in our supplies, the equipment that we need to do the visit, and now our tablets, because everything's on the tablet now, and whatever we need for that patient. But going from home to home, there's certain things that we have to do by, I guess, by law, by our standard of practice. We can't set bags down in one home and then pick it up and take it into another home and that kind of thing. If we do, we have to follow all of these protocols. And it gets to be pretty complex just in the things we have to do, putting down a bag barrier and things like that to set our bags on. And if we're in a home that happens to have any kind of infestation, which is just down south where I live, that's not uncommon. Like there's fleas and there's roaches and things like that. And if you put your bag down, it can get into your bag and then you carry that to another home. So I got to where I never just set my bag down. It was just easier for me to keep it on my shoulder. But then I had this big old bag and I started getting a lot of back pain and leg pain. And I'm like, I can't keep doing this. And I searched everywhere for a bag that I could wear that would hold all of my equipment and my tablet that I didn't have to hang off of my shoulder. And I couldn't find one. So I designed one and I made one for me. I had a bunch of the bags that I had bought. I probably had 13 or 14 different types of fanny pack bag types of things.
Yep.
And I had someone take them apart and just put them back together in a different way and make me one that worked. And then everybody was asking me about it because I could wear it as a hip bag, no pain. It held all my stuff. And people kept asking me about it, kept saying, I need one of those. So that's where we came up with the idea. My husband took that and went with some people in like Rochester, New York is where it went to. They designed it and made it and all of that. And that's how that got started.
And that's a huge deal for nurses.
It is a huge deal.
We have all these bits and pieces that we want to take into the home. We've got gloves, a stethoscope, maybe a pulse ox, a thermometer. We have alcohol preps because we're going to clean all the equipment when we get done. We have a box of gloves. We may have wound care supplies. And all of that stuff is okay to be in the home, but you can't just scatter it across somebody's surface.
Right.
Yeah.
Right. And they have to have hand sanitizer on the outside of your bag.
Right.
So that you could sanitize your hands every time before you put them in the bag and all of that stuff. So that's how I set that up so that we could follow proper bag technique. And we really do that for the safety of our patients. It's not even so much for us as it is for our patients. So we have certain very strict protocols that we have to follow in every home. And so I designed the bag to promote easy bag technique and make it simple. So it's just easy and it becomes a routine to follow it very quickly using the tag bag.
I remember when I first started doing bag technique, when you had to have a policy for it and you had to have training for it. And so we would use whatever barrier, back then it was paper towels or maybe it was a garbage bag. And so you had to have those things with you and you would set that down and then you would set your bag on top of it. I think we even used Chucks back then, the blue waterproof pads, which is a really expensive barrier, right? Because the barrier gets thrown in the trash.
Yeah.
And I remember families looking at me like, why are you not wanting to set your stuff down in my house?
Oh, yes.
And sort of being offended. And I was having to explain, this is part of our protocol. Basically, it was infection control, going from house to house to house and setting my bag down and having my supplies in it. But I remember it was almost something that I had to think about so hard, especially if you're being evaluated by your supervisor or, God forbid, a surveyor.
Yes, I hate that so much.
Yeah, because you had to open your bag, but wash your hands before you went in and got anything out of it. Mm-hmm. So if you're a family caregiver or you're a patient and you're watching a hospice nurse do that, just know that nurse is thinking about that technique, paying attention to it, and it's because it's a really important thing for compliance and cleanliness for us.
It is. And if you think about it, our patients are already very debilitated and very sick. So what might not make us sick, if we pick that up at somewhere along the way, could make them very sick. And, we are so careful about that because we want to make the end of people's lives the very best they can be. We don't want to make them sick.
Right. It's not our job to drag anything from home to home.
Right.
Yeah. Yeah. I think that's an interesting thing. And I remember when I was training on it, I would catch myself, dang, I reached into my bag, without washing my hands or sanitizing my hands. And it just became this focus. We used to practice in the office. Yeah, it was.
Yeah, it's not natural.
It's not.
But with my bag, it's pretty natural. It's pretty easy to do. So I kind of laid it out that way to make it super simple and kind of mindless now.
I like it that you don't call it a fanny pack.
No. It's a bag or a crossbody. It's definitely not a fanny pack.
No, thank goodness. Fanny pack, that's a whole really bad image for me.
Yes, me too.
Yeah. So a tag bag, right?
The tag bag, yes.
I like that. Okay. So we've talked about some of the challenges in hospice and in hospice nursing and the perception of the community about hospice. I want to talk about the good stuff, the cream. Describe a day that you've had working in hospice nursing that's one of your best professional memories.
That's so hard. That's so hard to answer.
I hope that means it's because you've got a lot of good ones.
So many good ones. Like every day is a good day. Every day that we have challenges, but the actual care of hospice patients, it's all good. I mean, I think that I kind of encompass it all into one, especially when we go into the home during the most challenging time of a patient's life. And we're able to really make a difference. More like when someone's in the hospital, we treat the patient that we're seeing in the hospital environment, but that patient in their home environment is very different. And so a lot of times treatments that are prescribed from the hospital or the doctor's office don't necessarily work in the home as the same way. And we're able to really assess and evaluate that whole environment and figure out what's going to work best for this patient. Oh, well, this doesn't work this way because what's going on in their house or whatever. So we can find things that work really well for the patients and we make a big difference. I mean, almost all of our patients start to feel better and a lot of times they're surprised about it. They're like, I haven't felt this good in years. And it's because we're there treating you every day, or we're available. We're seeing you a few times a week and we're doing all of these things to help you. And we can just make a bigger difference and really improve their quality of life. I love that. I just love that because we do that over and over and over for our hospice patients.
It's so true. That's pretty cool that you can work in a job and say that after all these years, every day I make a good memory.
Definitely.
I don't know that every profession can do that. Now, we have some bad crap that happens to us, right?
We definitely, we do. It's generally almost always not patient related. There's a lot of other stuff going on, but
sometimes it's regulation related.
Yeah.
That can be traumatic. But I think our relationships that we form with patients and their caregivers, I think that's a very special thing. It's a very unique, intense bond because we're going through something very intense and emotional and personal, something very intimate with someone we barely even know.
We do. And I learn so much from my patients because people, when they are faced at the end of their life, all of your filters go away. All of the masks that we wore all our life goes away. And they tell you what really matters. And I just love that. I love that. They give me so much advice, and it's amazing just to watch and to listen to the patients that we take care of.
Yeah, we get to be the recipient of all this life wisdom and really just to watch people as they move through what's an incredibly hard situation with grace. Because it's not just older folks, hospice, we treat younger people. No. We have pediatric hospice. That's not been my experience. I haven't done that kind of work, but it changes who we are, I think.
Definitely changes who we are. I have taken care of some pediatrics and it's quite different.
Yes.
And I think that sometimes as an adult, an older person, and we have an expectation of how we think we're supposed to feel or what's going to happen. And we kind of move towards that because we think we're going to get tired and we think that we're going to feel a certain way. The kids don't. They don't have that expectation. And the kids just live until the very end.
Yeah.
And they just go on doing what makes them happy and brings them joy.
I think they're open-minded.
Yes.
They don't carry the biases and the prejudices that we do. Shelley, do you remember the first time you ever took care of someone who was younger than you were as a hospice nurse?
Oh, yes. Yes. I will never forget this. It was a young patient, and she was a young mother, and she was 27.
Oh, wow.
And she was dying of ovarian cancer. And she had 2 little children. And it was so hard for me. It was so, even talking about now, I'm getting emotional. I'm feeling myself back in her home. I can just see everything in her home right now. It was so incredibly hard watching her, just knowing that she wasn't going to be there to see her children grow up, and her trying to impart all the wisdom on her children, a lifetime of wisdom on these children. And it was so hard. And she basically, she just did not want to let go. And, usually when we get towards the end of life, most people will accept it even before they're caregivers. And there's a piece about them. But this patient, it was so very hard for her. And she was so worried. She was fixated on the curtains in her house that they needed to be changed before she got sick. She had remodeled her house, and the last thing to do was to change these curtains. And she was so worried that her husband was not going to know the right curtains. So I ended up getting with some of the other nurses, and we went and bought some curtains for her, and we went back and we hung curtains for her, so that just to bring her that was that last little piece, that she needed to feel like she could die peacefully. And she died 2 days later. But I'll never forget her.
How old were you when you took care of this patient?
Oh, wow. I was probably in my 40s. She was in her 20s.
Yeah, I think sometimes we do talk about pediatric hospice. But as I got older as a hospice nurse, because I've been in this almost 15 years, at first I was always taking care of people that were, my parents' age or my grandparents' age.
Yeah.
And then I remember it was probably the worst day I'd ever had in hospice. I took care of a man with a brain tumor who was, I think, either my age or just a year younger than I was. And I was totally floored by how much of an impact that had on me. It was a big reality check.
It's different. And I think we have to learn that it's, because sometimes people will say, well, it's not fair, or why is this happening? But that is that person's journey, and everyone's journey is different, and they're on the journey that they're meant to be on, and we get to cross their path for a little while and share a little bit of that journey with them.
Yeah. And it's not fair. There's no answer to any of that. The why question, there's no answer to any of that.
There's no answer. There's not.
So, Shelley, how would you encourage other hospice professionals, end-of-life workers who are just starting out work with the dying?
I think that it is so important to listen to your patients. Take time every single visit, no matter how busy you think you are. You need to take time every single visit and sit down with your patient. And if you can, touch them, because I think touch makes a big difference. Hold their hand, lay your hand on their arm, look them in the eye, and just ask them how they're doing and what they need and what they're thinking about. And do this every visit, because you really need to connect with every patient, because every single patient you take care of is going to be different. Even if they have the same disease process, it's going to be a different thing, and they're going to have different needs. And so you really have to connect with that patient and listen to them to understand what it is that you need to do for them during this part of their journey, because it is always going to be different. And so I think that's really important. And then it'll make your job easier. I think it really, in the end, makes it easier, and you feel good about what you're able to do, and like you're able to go make a big difference in their lives.
Yeah. What would you tell a caregiver who is currently taking care of someone who's on hospice?
You're doing a great job. You're doing a good job. You are doing an amazing thing with this person that you love. To me, someone that is willing to take care for as a caregiver for somebody that is dying, that's the ultimate act of love. You're letting them be home where they want to be. And it's hard. It's so incredibly hard. It's way harder than anybody can imagine. And you're doing a good job. And some days are going to be better than others. And some days you're going to feel like you're doing a better job than others, but you're always doing a good job. And we're always there to support you.
I love that.
And to lean on the people that will support you and give yourself some grace and take a break every now and then.
That's great advice. Great advice. Shelley, how can my listeners connect with you and with the Amity Group? And how can they find your videos that you're doing?
So the videos I'm on TikTok, as long as we have TikTok, and then Instagram, LinkedIn. Also, I've started some on YouTube, and most of the handles are for hospice nurses. That's FOR hospice nurses. That's TikTok and Instagram. And then on LinkedIn, it's under my name, Shelley Henry. You can also look at the Amity Group. That's AMITY Group. And we have our website at amitystaffing.com.
Awesome. I'll have links in the show notes so folks can connect with you easily. Keep making the videos, Shelley. We need your voice. You're doing a great job. Thank you so much for talking with me today.
Thank you. Thank you. I've enjoyed this a lot.
Be sure to catch the next episode of the Heart of Hospice podcast. You can find more episodes on theheartofhospice.com. And don't forget to follow us on your favorite podcast platform. You can connect with the Heart of Hospice on Facebook and Instagram and send your questions or comments by email to helen@theheartofhospice.com. And remember, no matter who you are or where you are in your hospice journey, you are the heart of hospice.